All right, it's 6 o'clock. I'd like to call to order the July 10th Program and Budget Meeting. And with that, I will start by reading our mission statement. Macomb County Community Mental Health, guided by the values, strengths, and informed choices of the people we serve, provides quality services which promote recovery. Nick, you might want to hear this. Community participation, self-sufficiency, and independence. Next, I will take a motion to adopt the agenda.
So moved.
Motion from Linda, support from Chris. Any questions or comments on the agenda? All right, seeing none, all in favor signify by saying aye.
Aye.
All opposed? The agenda is adopted. Next is hearing of the public. Anybody from the public wishing to speak, give us your name and address. You have 5 minutes. Anybody from the public wishing to speak? There's another one at the end as well. Going once, going twice. All right, we will close the first hearing of the public. And we will move on to item 5A, request approval for printer and multifunction printer proposal with Applied Imaging. Can I get a motion to approve that before we discuss?
So moved.
Motion from Selena, support from Lori. You want to come up and give us the gist of it?
Sure. This would have been probably presented with Tom here as well, but he's out of town.
Okay.
And I read over this whole thing before I came down here today, and one thing that he probably underestimated is he said the age of our printers and multifunction units are 10 years old. However, back in 2006, we moved every printer and multifunction unit in there, and that was 13 years ago. So I think they're older than that. So in our multifunction units and our network printers are all getting old, and the cost to keep on repairing them is going to go up. This proposal, and there's 3 bidders mentioned in there. We actually have more than that proposed arrangements, but Tom's recommendation is Applied Imaging. So if I could focus on that. For one thing, it's cheaper by about $1,000 than what we pay now just to maintain our existing units, and we expect the cost of maintaining those units is going to go up because they're all getting old. And multifunction units are $5,000, kind of for a starter, to get anything appropriate. They're going to bring in, provide the equipment for us, and we're going to pay basically this fixed rate, which is cheaper than we spend now, just to do our printing. It'll also unify the printing platform, so everyone will be able to use a centralized printing solution. And with the badge printing, if you read that, that means we'll be able to provide people with badges that can walk up to any printer they need to get their document off of and wave their badge over and then produce their document. That'll also help us track printing by department and by people. It'll help us get a little better picture on the volume of printing we actually do, and help us make decisions going forward about managing that solution. Any questions?
Nick?
That sounds great. The only question I would have is, what does that do to the security of the system? I mean, we've already had one hacking problem. The fact that anybody can with a bad wave, does that create any additional? Technology is great as long as nobody hacks into it.
Yes, I know that.
Does that create any more danger?
No, the badge,
Just to read on.
the badge printing will actually add a little more security, so less chance that you'll send something to the printer that someone else will inadvertently pick up and carry off. And then, pardon me? Unless you lose your badge. I'm not sure about those solutions. As I said, I was working on other things. Tom put this project together for us. I don't think he knew that it was going to go before the board tonight, or he probably wouldn't have gone away. The answer to the question of, I think it raises our security.
You think it improves?
I think it improves our security.
And what happens if somebody loses a badge?
I don't know the answer to that one.
I guess the question is, can we send over here? I lose my badge, I lose my credit card and call the bank, they cancel. If I lose my badge and I call in, would you be able to then turn off access to that badge?
I'm I'm sure that's true, but I mean, Tom could be available for the full board meeting to answer those kind of specific questions.
That's usually how that works. At the state of Michigan, every employee has a badge and you scan it before you can print or fax or anything like that. And if you lose it, you tell them and it gets deactivated. So I know you're just double
I was
checking.
expecting the answer to be yes, but if I can't get an answer, that's the problem.
Any other questions? Nick, we'll get you an answer before full board. Kathy's pointing. Kathy, go
I
ahead.
submitted to.
Yes, I got you.
Okay, I think we need to hurry and approve this before we spend more money, but I'm glad that this got brought forward, but it's costing us to not approve it, so thank you.
All right, thank you.
I'm impressed the system made it over a decade. That's pretty good. Thank you guys for scraping by with that. All right, we have motion and support. All in favor signify by saying aye.
Aye.
All opposed? Motion passes, goes to full board. Next is a request to approve the Makosa final budget amendment for fiscal year 19. Take a motion to approve.
Move to approve.
Motion from Linda, support from Megan. Randy, you sure this is the final amendment?
Oh, I think so.
It's pretty definite.
Yeah. Yeah. There'll be additional adjustments, as there always will at the end of the year, so that we can make sure that we don't lapse money.
I'm just
Or
kidding.
less likely anyways. Kathleen, you remember Kathleen Marzinski, she's our finance coordinator for SUD services, so I'm going to let her present.
Okay, basically with the amended budget, not a lot of changes. We do look through like each of the providers, we see where they have been spending up to this point. We're most focusing primarily on the block grant and PA2 dollars because we want to allocate all of the block grant dollars to utilize first before the PA2 funds. Medicaid and Healthy Michigan, we don't budget for by provider. So we did some shifts based on how the programs are operating. If some providers were spending more for their outpatient services, we allocated more to them, but the dollar amount that we originally budgeted for the PA2, Medicaid, Healthy Michigan, that all stays the same, just shifting between providers. The biggest change is in the block grant summary, because that's an increase. We had an increase from the state for our STR grant. They called it STR NCE now, just to make life more confusing. And they gave us an additional $897,105 for this current fiscal year. That's composed of 3 different projects within the STR. One of them is our project Assert, and they gave $156,000. A prevention media campaign that they allocated $150,000. And then the last one, big one, is for the MAT services, intervention, and utilization, and that's like $590,000. The other increase the state gave us was under our SOR grant, and they originally had budgeted an amount of approximately $52,000, which was for this individual placement. And when they did it, they kind of like added it on to our SOR grant initial dollars, but didn't tell us, so we had to work to get a program in place. And so we had asked for an increase to actually get that program going. So they did increase our budget by $167,000 for that. And the last change, which is really called just provider fees, it's not money that we get, but we do have to report it to the state. So in this case, at the recovery center that CARE is organizing and actually getting it started, they have another funding source, which is SAMHSA, that is providing funds. So that's the additional dollar amounts that they're projecting that they will get from them.
All right, thank you. Linda?
Isn't it nice to, in the middle of the year, have to redo your budget because the state gave you more money?
Well, there are worse things.
That's for sure.
It's good work, isn't it? Thanks.
Any other questions or comments? All right, seeing none, we have a motion and support. All in favor signify by saying aye. Aye. All opposed? Motion passes and goes on to full board. Next is item 5C, approve Macosa's county budget for fiscal year 2020. Take a motion to approve.
Motion.
Motion from Chris.
Support.
Support from Selena. All right.
Okay. Now, this one's a little bit different because it's our full budget that we're presenting. So the format that we utilize is the same that we've utilized in the past, an executive summary that we've used because we felt it worked out the best. So starting with the revenue side of it, for Medicaid and Healthy Michigan funds, I do a historical trend analysis looking at not only what they have given us, but by member count per month. So then this way I can allocate or project for the future, based on the same percentages and fluctuations in the months and how the trend is growing or increasing in membership over the last couple of years. Utilize the same rate for each of them because I haven't heard of anything where we're getting an increase or a decrease in the rate for Medicaid or Healthy Michigan. My Health, which is a very small amount for our budget, pretty much that's a wash because whatever we do spend for My Health, we get from the CMH side to match it so it covers our expenses. PA2 funds, again, it's looking historically how we have gotten our PA2 funds. We generally get them like 3 times a year. So I'm kind of basing it on that. The state usually comes out with a projection amount, but not till after our budget is done, so I can't do anything about that. Block grant funds, now that one goes into a little more detail. Again, I'm looking over historically, I'm looking over the changes that we've had in the past year. I'm looking at any additional grants that we have gotten, those that are ending, like our STR grants are ending, so obviously I'm eliminating those dollars. We've got additional funds for the SOR grants. Those are continuing for another year, so I'm increasing it to include those. And that kind of sums up the revenue. County contribution is really just a small amount. It goes toward administrative expenses and just fluctuates based on the wage increase. Expenses, our salaries and wages, fringe benefits are going up. Primarily that's going up because we're adding back Helen back to the substance abuse, which is being moved over this year. So that's one FTE at an admin 4 level along with her fringe benefits. Plus the county had included in the budget a 2% wage increase for all employees. So that's also incorporated into the budget. Under general operating expenses, the biggest increase is really for medical supplies, which is for our Narcan, because we actually already have placed 2 orders for it, and each one runs around $200,000, and we're looking at maybe putting in a 3rd one this year. We have additional providers that are distributing the Narcan, so we are using more of it. We no longer have a use tax, so that cut out like $90,000 out of our budget from last year, which was put on Medicaid and Healthy Michigan, so that's no longer around. And okay, then contracted services, okay, under clerical and other professional, we have an increase of $43,000, and a lot of that's predominantly for the SOR coordinator. We had to hire a coordinator position required by the state under the grant. So it actually is being paid for 100% by the grant. We reduced the expenses under auditing because we used to have Experis come in and do the financial audit. They did it the last 2 years, which cost us roughly about $70,000. So we're bringing that back in-house this year again. We used to do it in-house with our current staff, so we're going back to doing that. The only other real significant increase is obviously for our providers, which is providing the services. When you get to like the 4th page, it gives you the distribution of how our changes are by services. So you can kind of see, like our SDA doesn't change. And this, again, this is looking at where we are this current year, how, based on how we changed our amended budget, for where the money is flowing, what services are needed more, what are needed less. And we have increased some areas like our residential and outpatient and recovery homes because we do have some RFPs out. So we're going to be looking to be adding additional services or expanding those services. The first pie graph that you have there is showing you our by funding source, where all of our funds are coming from. It's actually pretty evenly distributed, with block grant being 25%, and Healthy Michigan, obviously the big one at 29%. The last page, which has both graphs, you can see the comparison between the current year's budget that was originally approved and the budget projection for next year. So you can see the changes in the revenue, which is showing a big increase in Healthy Michigan revenue, and our PA2 fund balance. Our fund balance is budgeted based on what we plan to spend for our providers. And the expenses, again, the biggest change is our contracted services because we plan to be spending more for our providers, increasing services.
Thank you. Any questions or comments? Linda?
For the STR, that was good, good that we got that, and it funded some really unique and kind of, very beneficial services. So as they wind down or the grants go away and you budget for it, do you look at ways to maybe continue the service or
Yes.
some way fund it without the STR?
Yes, we are using like our PA2 fund balance for some, not all the programs, but some of the programs that Randy decides are beneficial and are really of value, then we are continuing on with the PA2 fund. And that's why for next year, it's the first year we're really going into our PA2 fund balance quite a bit because of all these programs we've had over the last couple of years. Like we've had the RFIs the year before, and we've continued some of those programs, so we're constantly been expanding.
Thank you. Thanks, Randy.
Any other questions or comments? I don't have any in front of Gabby.
Thank you. I know it's just dollar amounts here, but do you have to submit any projection of people served and people in recovery, recidivism, and things like that?
The only report that I wind up having to do is at the end of the year to the state, which is the legislative report, which shows the number of unique cases and number of people served. And that's at the end of the year after the data. And it's called the legislative report. I believe it's, it goes to the state.
Just a comment to that effect is that I don't have the most recent numbers on that, but from 2016 to 2017, we went from serving 6,000 individuals to 8,300 the next year. And that was right about the time when we started implementing some of the SDR initiatives.
And is that because more people are identified, or?
I think it's a combination of things. We've stepped up our referral methods. We added, at that point in time, or just before that, we almost doubled our service capacity. We added a couple residential programs, a couple MAT programs, some recovery. So we had more capacity so that we could serve them when they came in. So we're doing better at serving more people now. And now we're trying to refine the system so that we can serve them better, not just more. So.
Right, and you've talked about that before, some of the things that you're doing to increase the effectiveness of the service to people being served. But I'm just curious how much that goes back and forth between the state. Not much, sounds like.
To be honest, yeah, we give them whatever they ask. and we have, for SDR, for the SOAR funding, you got all these different funding tracks that are going at the same time, but on different timetables and different focuses. We report to them every month on how we're doing. It's not a detailed report, but it talks in terms of, what are our barriers out there, how many people are we serving, the things that we're talking about now. All those things get done on a monthly basis, so they know what we're doing and what we're not doing too. So
question from my perspective that you're not doing stuff, and there's the needs out there, and you're doing everything you can to meet that. At some point, the whole community needs to know, and I'm talking wide community, including the state, the country, whatever, are we making a dent in this? And I mean, so that's, you don't have to answer that, it's just my.
No, and I think that's a valid point. I think that, we're trying to determine, they gave us this money, right? And so we started these initiatives, right? But we only get 2 years to do those. And in most cases, and then you start asking questions, why are we having an impact on it? Well, you're really not going to even start to have an impact until you go 3 years, which is at least, but we try to collect that, we give them that data. And that's why right now we've decided to support any of the initiatives that the state supported prior to the end of their grant periods until we have a good sense as to whether we are having an impact or not. So after this year, I think we'll be making more decisions about which ones we're going to continue to fund and which ones we won't. And the other thing is, we're living in an environment now that we have urgent needs, and that's why we're getting the money. But we would be a fool to expect that this is going to continue for any length of time. As long as there's an opioid problem that's, or epidemic really out there, they're going to be sending us money. But eventually, that we're going to be back. Well, we won't be back, I think. It's always we still have HMP and Medicaid. We'll still be able to provide services, but we won't have the money that we have anymore. So, and the opioids are the number one thing now, but I'm hearing up in St. Clair County, for instance, that they have a meth problem that's bigger than the opioid problem that they have in their county, and which concerns me because I live there. But so it's going to shift. I mean, the substance abuse problem is not going to go away. It's just going to change as time goes on. I think we will get a handle on this. I think, but it's changed so much from year to year. First it was heroin or heroin only, then it was the opioid prescriptions, and then it became fentanyl mixed with everything else out there, making your death cocktails with it.
Right.
So
It's a supply and demand, and oversimplifying.
Yeah.
It's a supply and demand. I also realize there's behavior involved, but sometimes we work on the supply, so we try to get rid of opioids, but then if they're picking up something else because of the behavior, then we're not being successful. But if we can,
Get a
do something
control
with
on it.
behavior, then we're being successful.
we've got a lot more tools than we ever had, so that's a good thing.
Linda?
To Kathy's question too, aren't some of, or most, or all of your contracts outcome-based? That you don't have specific outcomes that you have to measure?
Well, we have two kinds of contracts. We have performance outcome contracts, which are typically tend to be prevention-based. So they give us a budget, we reimburse them for all their costs, but they have to give us so many outputs before the end of the year. So that usually is how many units did you have, how many people did you see. If they meet that, they get the full amount of their budget. If they don't, then we deduct it from their final payment. Then the other one is a fee-for-service or arrangement that we have with all of our treatment providers. And those are, and they report on the focus system, and they provide a lot of demographic information as part of that, and that information goes up to the state. And I guess that's all I'll say about that.
And then, just someone asked me this and I couldn't remember, but do we have a MAT-assisted, while you're standing there, I remember, Randy, do we have a MAT-assisted recovery home in Macomb? That's a problem.
For recovery homes, we have only, well, there are two homes with one owner, no, only one home that serves the MAT.
We do have one that serves MAT.
Lighthouse, but we also have coming online, it's going to be Sacred Heart, that's through a SOAR grant. They're opening up two facilities, one male, one female, to serve people that are receiving MAT services.
And they'll be in Macomb.
They'll be in Macomb, yeah.
Thanks.
And Linda, MAT is?
Medical assisted, medicine
I wanna
assisted
hear this.
treatment.
Thank you.
Medicine assisted treatment, like,
Medication assisted treatment.
medication
That's,
assisted.
that's
Methadone,
Vivitrol.
Suboxone.
I saw some whispers, so
I can tell you the ingredients.
for the good of the group. Okay, any other questions or comments? All right, seeing none, thank you. Oh, Randy, you have a question?
I missed it in the first now, but I should just note that because of the Public Act 500, and we have an Oversight Policy Board, that the Oversight Policy Board votes, and they make the decisions about local funding, and this board makes decisions about all the rest of the funding. So they voted today for both. They voted to approve the budget, and they also to recommend back to your committee. So a lot of my influence on that.
Thanks, Randy. All right, we have a motion and support. All in favor signify by saying aye. Aye. All opposed? Motion passes. Thank you both.
Thank you.
All right, next we are moving on to item 5D, request to approve residential lease A. Take a motion to approve before we start discussions.
So moved.
Motion from Kathy, support from Nick. TJ, I got a question for you. Since Tracy's not here, and I see some scribbles on the first page of this one, and I think it's on another lease as well. Something about, I'm having a hard time reading it, but something about a shorter term renewal.
That was a recommendation by Corp Council in our direction moving forward. Decide, depending upon what we're going to do, it was just Corporation Council's decision or recommendation that it be made that we consider moving to a shorter term lease in the future. That was it. It wasn't necessarily specific to these leases. He simply, Corp Council simply wrote that note on those leases. So that would be something internally we would discuss, decide forward. Keeping in mind, and Tracy and I discussed this earlier, if we move to a shorter lease, we could expect much more pushback in the lease amounts that we currently are up against now.
Thank you for clarifying that, because I could read most of it, but not all of it. I didn't know where it would come from, so I was...
That was Aaron's scribble.
Perfect. Okay, are there any other questions or comments? Ken?
This one is still a 5-year, I see the others.
That's correct. All
There's
three.
no change.
That's correct. That's correct, other than in all three of these two, for expediency. The only thing that has changed is a slight increase based on either insurance or taxes or both.
Any other questions on A? All right, I don't see any, so we have a motion and support. All in favor signify by saying aye. Aye. All opposed? Motion passes. Next is 5E, residential lease B. Take a motion to approve. Motion from, is that Megan?
Support.
Support from Lori. Any questions or comments on B? All right, seeing none. All in favor signify by saying aye. Aye. All opposed? Lease B is approved for full board. Next is item 5F, residential lease C. Take a motion to approve. Motion from Linda.
Support.
Support from Selena. Any questions, or my right ear is better than my left? Any questions or comments on this one? All right, seeing none, all in favor signify by saying aye. Aye. All opposed? Motion passes. Thank you. Nice and easy today. Next is 5G, request to approve the Macomb County Community Mental Health Services 2019 through 2021 Specialty Service Contract. Take a motion to approve. Motion from Chris.
Support.
Support from Linda. Alrighty, let's roll.
Good evening. I thought it might be easier just to start with the list of just some basic things that you were given today. Just some minor changes are removing person or consumer and putting in person served. We did a lot of, from your recommendation from our board work groups last year, getting rid of some of the attachments and pushing that into the boilerplate so the contract is shorter. So you'll see they're listed out here. and they are put right in there with appropriate titles for those sections so that you can reference those. And in doing that too, we streamlined a lot of the information so things weren't repetitive. In the previous contract, it might have been in the boilerplate, more broad, and then been in the attachment, more specific. So now all of that is just one. Some of the pieces still remained as attachments, and those were per that division's request, or if it was something just so specific, we wanted it to be really pulled out so that the providers could see that information. But those sections were pushed together. We did add the business associates agreement and the qualified service organization agreement, which are requirements. A lot of language change was put into this boilerplate. Some of those are federal rulings, PHP contract, I have to look up the acronym so I don't say the acronym for you. Health Service Advisory Group, HSAG is the acronym. We have those audits regularly, so all of that contract language was put in there. So a lot of the requirements that we have to follow were put into this document. I would have preferred to give you a red line, but we really completely redid this boilerplate. So if I would have given you a red line, it would have been 50 pages of strikeout and 25 pages of new information. I worked on this with Helen, Kimberly Cope, and then one of Kimberly's staff, and we put a lot of work into it, almost a year's work, and really went through every requirement, very detailed. We consulted with the other divisions to see if there was any changes to their divisions, policy updates, any addendums or changes that we had previously made were put into this, so it really is a whole new contract that you're looking at. And it's a very broad overview, but as you read through it in the past week, did you have specific questions or areas that I could direct you to or highlight for you?
Nick, go ahead.
One of the concerns we've had recently with a lot of our providers is quality levels, and it looks like the only recourse we have is to the contract. Can you point me to where in the contract we can do something other than just simply terminate? You know, because
Yeah.
it's like the death penalty for a traffic ticket. In some cases, we want to be able to work out as well as terminations and alternates. So it's significantly.
The contract is going to be a little bit more overarching, where you're going to see in there all of the requirements that they have to follow. There's a lot of things that they have to put in the EMR to make sure we have correct data reporting. VHTEDS is mentioned, you've heard us talk about that. Those are, a lot of those pieces went into it so that we can make sure we're holding them to those standards that we are held to. But a lot of the pieces that are going to come when you're holding a provider accountable for their quality or their performance is going to come in our policy. So the contract's going to reference policy, and within that, we have auditing. And so we have a policy about auditing. Auditing is mentioned in here, and actually my division's currently out doing that auditing of our outpatient case management and sports coordination providers, and we're about halfway through, and I can tell you it's actually going very well. We're very pleased with what we're seeing. We have a team of about 4 of us out there doing it. So those are the areas, the auditing, the sanctions that we have, and that's not going to be something that we're going to put in the contract, but we do have a process, and I probably provided it at the board work groups, but I can give it to you guys again if you'd like to review that, especially because we have some new board members, and so it might be a good time to refresh your memory on that. But there's a 4-letter sanction process. So, one is more of a letter, this violation has occurred, or this is not being held up to the quality of the contract, or what have you, all the way down to a recommendation for termination. So there's a concrete process for that. And then we have the meeting that we did monthly. We've moved it to quarterly because of the need. We just did not need to meet monthly, especially now we've been doing it over a year, and the team is really used to the process, but it's where all of the administrative team can report out on each of the providers, their performance. We have a metrics. We have a form that somewhat looks like the incident report form, so each area, whether it's claims or safety, is identified so that we can measure the performance and the severity of whatever it is occurring. So those are the pieces that are really giving our division the overall, should we contract with this provider, should we not? Should we cite this provider, should we not? Should we do a cap? Should we go in and just provide technical support? So that's where you're going to see those things, not necessarily spelled out in the contract.
But are those things incorporated or referenced in the
Yes,
contract?
because, the auditing is, and then the contract references that you have to follow all MCO policy and procedures, and those are policy and procedures. It's easier for us to, and more efficient for us to build those into the policy and procedures rather than in the contract. So that's something that we've tried to do over the past couple of years.
As long as the contract references.
Absolutely.
Incorporates it. So we've got a range of
Mhm.
potential, just what for lack of a
Yep.
better term, if somebody isn't living up to their requirement.
Correct.
Whether it's a policy, the policy is fine with me,
Mhm.
as long as the contract says you gotta follow the policy.
Absolutely. Yep. And that was a lot of the cleaning up that we did as well, is there was a lot of policy in the narrative. It doesn't need to be in this. It needs to be in the policy, and this needs to just say, you're required to follow policy. So we pulled a lot of things out that were duplicative, and that was one of the asks. We did the board work groups, and then we also were meeting with the Macomb Provider Alliance Board, and they had a lot of recommendations, things that were very helpful. So we, when Jim was still with us, it was Jim and I, and we must have done that for about 6 months. We met with them monthly, and we went over the entire contract and got all of their feedback, so we took all of that into consideration. We did a lot of anything that was questioned by that group. Let's cite the source. Let's go back. Is it in our contract? Is it in Michigan Mental Health Code? Is it in Medicaid Manual? Why is this in our contract? Is it in the county requirements? So we validated everything that we put in there, and we took out what shouldn't be in there. So I really feel proud of this contract, if I can say. We really put a lot of hard work into it. I hope that it meets your expectations, and if there's thoughts that you have around it, we're happy to take those into consideration. The plan would be, with your approval, to send this out to the providers next month with a 60-day turnaround, so we start with it 10/1. And that's shortened as well. We used to have a 90-day turnaround. What we found was it was too long. Providers would forget. They wouldn't get their stuff in on time. At the end, we're scrambling. It was just not necessary to give them that much time. They're already aware of the new date, and they said, absolutely, totally fine with that. We'll get it done. So they're waiting for it.
Dave?
Nick, to your point as well, with Christina's leadership, we were approved for a learning collaborative with the National Council for value-based contracting. So we're going to work with a group of our staff, and the intent would be that our contracts could then have clear sanctions and clear incentives for our providers in all of these key areas. So that's definitely one of our goals for next fiscal year. So you might see some additional contract tweaks, but we're off to a really good start.
Kathy?
Thank you for all the work on that. I always like it when it's smaller and easier to understand. And you answered one of my questions, was going to be, did the providers participate in this? So you already answered that. The other would be the list that's in there. Those are the providers that are going to be receiving this contract and from whom we're expecting
Yes.
them to sign.
Mhm.
Can a provider come in after this, after October 1?
Yeah, I can always choose to provide that recommendation to you to onboard another provider, and in fact, I do have some that will come to you next month. The list that you have is people that are currently providers. So I didn't want to confuse you with, here's current providers, here's new providers, and this is just a nice clean list of current providers that I'm recommending for recontracting, and then you'll get along the way new providers, whether we're doing RFPs, bringing people on for urgent or emergent needs. If we don't have that in our panel and it's something that we need, it's a network adequacy requirement. The state is really monitoring the network adequacy, and they're making some mandates, and so if we have to fulfill those requirements, we might make that recommendation to you. But yes, this would be the contract that they fall under.
So we're not necessarily approving the list of vendors, other than, because you're allowing them to have it, obviously you're approving them, but once in a while we get complaints. It's not very often, but somebody wants, as you know, somebody
yeah.
wants to become on that list, and for various reasons, they have to wait for the new contract process.
They really have to wait for the RFP process. We have a procurement policy that we follow, by your direction, pretty strictly, which I think is a very good thing. And I'll tell you, I presented at the Quality Conference a few months ago up in Traverse City, and we were presenting, a group of us did it, 3 of us, the other 2 were from CMHs, and we were talking about procurement and onboarding and what we do that's successful. And it was a large room of people that were all kind of in the same boat with that. And it was exciting to see what the different groups are doing. But one thing that really was praised by that audience and the other presenters is our process for procurement, following that RFP process, having a solid policy around it, onboarding them in a succinct pattern. So that's one thing that I think you guys that have been with us for a while know, that It's not often I'll bring a provider to you under urgent or emergent. They're typically an RFP, and that is to ensure the quality of our provider network. And I think that that really does help. And we do have people that will come to you or perhaps to Adam or Dave and, I want to get on a panel with you, what's the process? Or they'll call my division weekly. But I really hold to that RFP process because it provides the quality. We have, through the procurement process, we have other divisions participating in that meeting. We have quality at the table, finance at the table. And so we're getting more input than just what my division might see. And I just really value that whole process, and I think that that keeps our network what it is.
Thank you.
Any other questions or comments? All right, seeing none, we have a motion and support. All in favor signify by saying aye. Aye. All opposed? Motion passes. Thank you, nice job.
Thank you.
Next up is item 5H, request to approve the revised policy MCCMHMCO policy 2-006, service provider appeals. Take a motion to approve. Motion from Nick, support from Kathy. Any questions or comments on this one? Dave, you want to speak to it?
Yeah, basically, we modified this policy to reflect current practice. With Dr. Hosef when she retired, we do have Dr. Carmen Serpa as our interim medical director. We have a requirement and a need for a 2-level appeal process. Primarily, it's from the community inpatient psych hospitals. So we'll say, we'll deny at level 1, they'll come back and request that be looked at again. So the policy was modified to allow for a PhD psychologist, which is appropriate for the first level appeal. The second level appeal will go to Dr. Serpa. And as we are looking at other options for our psychiatrists, but that's the way it stands right now, so we just modified the policy.
Selena?
I'm going to recuse myself because I oversee this division.
Thank you. Any questions or comments for Dave on this one? All right, seeing none, we have a motion and support. All in favor signify by saying aye. Aye. All opposed? And we have one abstention from Selena. All right, motion passes. Next is item 5I, request to approve PIHP fiscal year 2019 contract amendment number 4. Take a motion to approve.
Move to approve.
Motion from Linda. Is there support? Support from Selena. Dave, do you want to touch on this?
I mentioned earlier, the department is working on the new waivers, which will go into effect October 1st. And in their dialogue and collaboration with the CMS at the federal level, the feds are requiring that the state put additional language and terms into the contract. And every time that happens, the trickle-down theory, it comes down to us. So this is the 4th amendment, which I believe is probably the most amendments to a contract, but that's why they're changing the whole entire waiver process. The 1915C waivers are moving to the 1115 waiver. So little things keep popping up. There is an expectation or a request from the department that this be signed and returned by the 19th of this month. I have submitted a request for an extension since the full board does not meet until after that date. They have yet to respond to my request. So you could approve it now or wait to the full board and we'll just, I'll inform the department. I'll be there tomorrow. That it won't be signed until and available till the 25th.
Kathy, did you have, yeah.
This has happened before, and they've given us, because it's only a matter of a few days.
Right.
Let's just move it on.
Right.
Call a special meeting, if I have to.
just a quick question, what would happen if we didn't approve it by then? I know it's probably just a couple days, could anything?
I would get a sternly worded email from you. No, I don't think anything catastrophic would happen.
Yeah.
And if it did, it would be what Kathy was saying, they would call and say, we have to have this because we have to get it to CMS by this date, and then I would contact Kathy about a special board meeting.
Any other comments or questions? All right, seeing none, we have a motion and support. All in favor signify by saying aye.
Aye.
All opposed? It has been approved to move to full board. Next is item 5J, request to approve the fiscal year 2020 PIHP contract. I'll take a motion to approve. Nick, do you want to?
Mr. Chairman, I would move that we report this to the full board with the recommendation that we direct the CEO to sign the contract upon the approval of the full board, as long as it's co-signed by the county executive, as is the case with all contracts. And I want to specify that because this is the big enchilada, this is the big money. And for the newer board members, you ought to know we've been advised by Corporation Counsel that if we entered into a contract without it being co-signed by the county executive, that the board members and the CEO would be personally liable. This one's so huge, I don't think any of us, we would be able to pay it. I'm not a poor person, but I know I couldn't afford this one. So I just add that as a specification simply because that's the normal requirement. It's the normal way we do it, but I just wanted to specify because of the size of this particular contract.
Is there support for
I'll
Nick's?
support that. If Nick could please repeat it.
Well, be on. I'm moving that we report this, we recommend to the full board that the Macomb County Board of Commissioners, Macomb County Community Mental Health Board approve the contract, direct our CEO to sign the contract on our behalf, provided it's first signed by the county executive.
Still support it.
Okay. Thank you. Are there any questions or comments on that motion before I turn it over to Dave to talk in length about this contract?
Please.
All right, Dave, go
Or
ahead.
not.
Yeah, we're not, it's Steve's choice.
Because this is so important, I thought I would read.
Yes.
For those, this is the contract, so, anyway, we have been meeting weekly with the department. There's been face-to-face and teleconferences going through this contract in great detail. Those calls continue, and again, I'll be in Lansing meeting with the department tomorrow morning. There are some new items that have popped up that would cost us money to administer, and there's no indication of where any new money would come from for those. Other than that, things are moving along fairly well, but we are trying to continue to reinforce with the department where's the money for this service. They've gotten really good at adding things to it, as you can see by the thickness of that document. So by the board meeting, I would like to be able to, I can share detailed feedback from the rest of the PIHP group at the state level. And Corp Counsel has this document for review as well. So more information will come as we continue to make our way through this.
Nick?
David, one of the thorns in our side with this PIHP contract, it's not new, it's been going on for several years, is that we're asked to sign the contract without knowing what the rate reimbursement is. That's akin to saying, hire somebody to paint my house, and he'll tell me is paying it. I mean, you don't really ordinarily do that. And I would argue, as an attorney, that it's not a contract, because if you leave out an essential element, like what you're getting paid to do the services, you don't have a complete contract. I raise that not because I'm objecting to the contract, but because I hope that in the deliberations with the department, you would continue to raise that problem. That's a defect of the town, the department. The department needs to have PIHP providers, and the PIHP providers need to know what their reimbursement rates is. The fact that it takes them 2 months into the fiscal year to give us our rates makes our life very difficult, and it is wrong, pure and simple. And I would hope that with the new department and with the new administration, we could say, look guys, this isn't the way anybody does business. Get your act together so we know what our rates are. We can argue about how those rates are determined. They have to be actuarially sound under federal law, and they're determined through an audit process that we have a lot of criticisms of the last one, so we can argue about that whole process subsequently. But a simple tenet that says, determine your rates before you send the contract, or your proposed rates before you send the contract, so everybody knows what they're doing, I don't think is an unreasonable request. So I only raise that to urge you in those meetings you're having to really stress that point, because it's annoying. And it creates serious problems for our financial people and for theirs.
Any other questions or comments for our director on this one? All right, seeing none, we have a motion and support to move the full board with next edition of, yes. All right, all in favor signify by saying aye.
Aye.
Aye. All opposed? Motion passes and heads to full board. Next is item 5K, Macomb County Community Mental Health Fiscal Year 2019-2020 budget. Take a motion to approve. Motion from Chris. Is there support?
Support.
Support from Dana. All right, let us know how we're doing. You're not smiling.
Always. Good evening. Actually, I'm not sure if, I have 2 items on the agenda, both the budget and also the reporting of the second quarter mid-year report for 18-19. And the thought was if I could actually switch that, I could go through the board and recommend that and go through the mid-year report first and then finish with the budget.
It's fine with me if nobody has any objections. All right, go for it.
A few comments I'd like to point out. As for the executive brief, it is the format that you are familiar with, where I report out on the Medicaid, Health of Michigan, Bennett combined, along with general fund. With that being said, if you've noticed in the packet, there's an additional piece that's basically the same information, but in more of a narrative form. After speaking and meeting with Dave and also with Adam, I'm going to go through that summary actually today. It has all of the supporting documents behind it as well. And also with that being said, because there's many new board members, we have again Dave and Adam joining, we thought this might be the best opportunity to have a board study session in the very near future and actually evaluate what information would be more beneficial in possibly a different format. If it's something that you want to continue with, for example, in this format, we can definitely do that. And in addition to that, I'll be reaching out to other regions and see what type of information that they share with their board members and try to, possibly share that with you as far as offering some other areas that we could look at and analyze more regularly. Additionally, at that board study, we could also have more of a training session, again, with many of you new to the board in some of our reporting. It might be beneficial more than having questions here in a public forum, something that we could really dig in deeper at, again, a work study. And so I'll work with Dave and Kathy and Phil and see if we can get something on the books rather soon. So if that's okay, I will move on then on the narrative actually for the executive brief today. Again, this is reporting out on the mid-year FSR, which was actually, it was due originally in May, but the state actually had some issues with their template and it was bumped to June. So again, protocol has been that I report out after we submit it to the state. So there again is the delay. Unfortunately, it's based on actual information that we started preparing the end of March. So it is rather outdated at this point. The next report will be due in the middle of August, which will be reported out to you in some format that we decide in September then. So keep in mind that again, it is a moving target. It is based on actuals and then projections based on the best information that we had basically working on up until I'd say about the middle of May. For Medicaid is where I'll start. We had a beginning ISF actually that had a zero balance coming into that. We had Medicaid revenue projected to be roughly $170 million for CMH alone. We combine that with substance abuse of about $4.2 million for a total of $174.6 million. Our Medicaid expenses for CMH project to be roughly $176 million, substance abuse 3.2 for a total of $179.4 million. That results in a Medicaid deficit of $4.8 million. That Medicaid deficit will be funded with a few areas. We have the Healthy Michigan surplus, we have a Healthy Michigan slight ISF balance, and then we'll be using a portion of local unrestricted funds to cover that deficit entirely. Moving on, the Healthy Michigan, we did there have a slight beginning balance of $175,000. The Healthy Michigan revenue is projected to be $13 million for CMH, $7 million for substance abuse, for a total of $20 million. The CMH expenses project to be roughly $11.9 million, substance abuse 6.3 for a total of 18.3, which resulted in a Healthy Michigan surplus of $1.8 million. Again, that Healthy Michigan surplus, along with that small beginning ISF balance, will both be directed to help fund the Medicaid deficit. We also report this out in a combined format, taking Medicaid and Healthy Michigan together. So the combined beginning ISF was $175,000. The combined revenue for CMH projected to be $185.5, for substance abuse $11.3 million, for a total of $194.8. Again, that's the projected revenue combined Medicaid Healthy Michigan. The combined expenses for CMH projected to be $188 million, for substance abuse roughly $9.6 million, for a total of $197.8 million. All combined, this results in a deficit of $2.9 million. That will be funded by the remaining ISF balance and unrestricted funds. Again, all of the supporting line items for this are in the attachments that you do have, where it outlines, again, all of this for, again, the 18-19 projection, and it bumps it up where you can see where we were at for the 2 previous fiscal years. Moving on to the lighter side, we have the general fund. CMH did start the fiscal year with a carry forward from 17-18 of $406,000. The CMH general fund allocation is $8.1 million, which totals about 8.5 that we had started going in. Our general fund expenses project to be $5.7 million. So therefore, we're looking at a surplus of roughly $2.7 million in our general fund. And again, with that being said, this is a moving target. I know we've talked about that many times. I do expect improvements based on, again, we're meeting regularly internally, looking at our practices, looking at cost savings, and we are looking and seeing evidence savings. So I do expect that the report on our August report will definitely should be showing you improvements.
Linda had a question.
I have a couple. Thanks, Cindy. So this is complete through second quarter?
The second quarter is, again, it was done, it was supposed to be in May, so when we start reporting it out, we actually have to cut off. So we did this through, it was like the end of March, when we close our books, was as of that date.
First quarter, right? That's first quarter, right? The end of March?
No, second, from
Oh,
October.
from October, right,
Correct.
okay.
Correct.
So, yes, so this, okay,
Correct.
so we don't have third quarter
Correct.
information at all. Okay. So my first question is, can someone do the math and tell me what the ISF of 7.5% should be? It's what? 12?
Roughly, between 12 and 14, I mean, it depends what we're looking at. If we're looking at combined, if you're looking at it for Medicaid, looking at it for the HMP.
Say 12.5. So if you look at this, the Medicaid and health, if you should be combined. No, the one with just the Medicaid. The ISF shows a deficit of 2.7, but it's really plus not having the required 12.5, right?
Well, that's the question on the table that remains as far as being fully funded.
Which is 14 million.
That 7.5 is what they put as a top bar, as our maximum that we could have to be fully funded. The jury's still out as far as what we need to have in there. So to look at that, I guess I would caution you that to throw that in. Just look at the deficit as
But
far
it's
as.
always been in here before until very recently. The ISF, until maybe the last year, the ISF amount, because we had some.
Correct.
So there was always a figure in there, and so it was always something that we considered. So when you say the jury's out, when do you expect, I mean, isn't that a yes or no answer from Lansing that, do we need the 7.5 or do we not need the 7.5? And so you're saying Lansing's not telling us?
Every time that we've asked, if Dave, if you'd like to speak to that as well.
Yeah, that question has come up directly with the department. It is the maximum amount that we're allowed. There is no bottom number. There is some general generic language in the contract that says you need to have, funds to operate in general terms like that. But they've not given a specific for instance, or an example, other than the actions that they've taken with Lakeshore.
Right, I was going to say, if you want an example, Lakeshore is an example. Right. Okay, so,
one other addition is jumping ahead. The ISF is in the budget for next fiscal year. And there's some good news. I don't want to take anything away from
okay,
this.
good. I'll wait that. So I have one more question on the general fund part. The general fund has a surplus of, what's the general fund surplus? 2.7 million. Now, when I first came on the board, when we had general fund surpluses before, that was a problem, and we started writing contracts right about now, because it had to be sent back. Is that still the situation? We don't want to lapse any money, right?
Correct. And that still does remain. So we did have a slight lapse actually last fiscal year.
We don't want a lapse, when we have so little general fund money, this is just my opinion, when we have so little general fund money to meet the needs that our community has, we don't want to lapse any money, in my mind. And so we sure don't want to lapse 2 million, but how do you spend it before the end of the year? I thought we needed to spend it. How did we not? We told you to make cuts, but how did you not spend general fund at that level?
And again, what I could say is that right now, with the projections and because of the cost savings, but it's something that, again, internally, with close monitoring, for that same reason, looking at our benefit plans, looking at what we're providing, looking at areas where we do need to spend those funds for our consumers and put it back. and with our, again, the UM team, and working internally with our programs.
So
Because
that's a
you're
goal
right.
for this fiscal year to not lapse that 2 million?
Correct.
Okay, great, thank you.
Nick?
It's a double goal. I'm trying to follow here. So your projections as of mid-year is if everything stayed the same, we would be in deficit by about $2.5 million. We would pay that out of how much is currently in our ISF?
Well, we drained the ISF, the beginning balance was $175,000.
So you drain that out.
Correct.
That would still leave you with $2 million plus deficit. You could use general fund to cover that, right?
No, we cannot.
Why not?
Those are just the rules. We would be using our local unrestricted funds.
Not general fund, it was unrestricted.
It is, but it's a fine line to how to describe that, but it's a different category.
Okay, so I have two questions. How do we cover the 2.5? And you're saying local unrestricted funds, but I don't know what that means. And how is that deficit reflected in the carry forward? I think you did it the right way. It was do this budget before we do the next.
Right.
Into the next budget year. Because the PIHP is Medicaid and health and income. The general fund is everything else, which is practically nothing else. So as we sign the PIHP contract, as we move forward on the PIHP contract, the first liability is 7.5% that Linda talked about is ours, which is why we want to have an ISF and did traditionally have an ISF roughly equivalent to 7.5%. Because of the cuts from the federal and the state level, and because of the nonsense of the Medicaid, we exhausted the ISF. So we're currently sitting with essentially no ISF. But you've got to cover that 2.5 million somehow.
And that's where the fund balance that we have, that's the Center County books.
So how much is in the fund balance account?
I don't have the exact total right now, but we have enough to cover the 2.7
In round
of the
numbers, how
deficit.
much is in?
We have roughly 4 million.
Roughly 4, okay, that's the 4 million I keep hearing about. I got you. So there's this confusion going on among people who have been discussing this thing as to whether or not we have reserves of $150 million, which is the ISF, or $400 million, which is $150,000, or $400,000, which is both. I'm used to dealing with state budgets and thousands of surrounding areas, hundreds of thousands of surrounding areas. No, but 150,000 is the way we report the state. There's some suggestion that really is more like 450,000, depending on how you calculate it. And then there was the issue of the formula. So what I think I'm hearing you say, correct me if I'm wrong, is that at the end of the day, we exhaust the ISF fund, and we dig into our current $4 million reserves, cut that about in half, and we go into the next fiscal year with only $2 million in reserves, no ISF to start, right? And figure out how we go from there.
Correct.
Am I in the right place?
You are, except I'd just like to clarify regarding the $4 million. The $4 million figure seems to be coming up quite frequently, and there's a lot of 4 millions coincidentally. There is a $4 million figure, roughly, give or take, it's not the exact figure, that is our current unrestricted fund balance that we have on our books. There is a $4 million figure out there. That's our annual county contribution allocation. There's various words on there that is a local match, and it actually,
10% of the
it-
state.
right, and ironically, it actually comes out to be roughly $4 million. And that's, again, a local match that we're obligated to be receiving. They're obligated to provide to us.
I assume we received that for this fiscal year.
Every year, it's put out there as an annual contribution.
Yeah, it's in the county budget, and it's
Correct.
money.
Correct.
So, and that's by operation of state law. So they have to match 10% of the state funded dollars as opposed to the federal Medicaid funding. Comes to roughly equal.
Yes, actually, it's a part of, I believe it's section 928.
in the mental health code.
Right.
Otherwise, we wouldn't get, I mean, if the county didn't put in the 4 million, we would get the 200 million. So, you know, it's a county match to the federal dollar. So that money comes in, but that's in the bulk of everything else. That's not separate dollars. That's county money that's part of the match. So it's used for both services and administration and everything else.
It goes to various line items within the budget.
It goes throughout the budget. So, but when we get down to the bottom line in terms of how much we have, what you're saying is of the total amount of revenues coming in this year, this fiscal year, we're spending roughly $2.5 million more in expenses than in revenues. And so we eat up the ISL. Next year we go to a zero ISL. And we eat up roughly half of our other reserves, which were at $4 million, and we eat about half of that. Right, do I have that right?
It
On a
is,
projected basis, I understand.
based from the mid-year, but again, from what we're even seeing since the mid-year, we're projecting that we will be still having somewhat of an ISF balance for the next.
Now, that's where I want to ask you a little bit more in terms of questions. And some of it will get to the budget, and I'll save it for that. But the question in terms of the other end, where your projections could vary from reality. What are we seeing in terms of the number of people served? Is that varying? And the level of the acuity level, because that's what determines how much we're paying for the person. Are we seeing alterations in that, the changes in that would impact the acuity? If you're saying that projections we're going to spend less in the second 6 months than we spent in the first 6 months, but we're not changing our service level, that sounds like you're saying there are less people asking for services, or they need fewer services than in the first 6 months.
And I think that's more than just a quick answer that I will actually defer to Dave as well. What I can speak, I don't have a number here for you as far as person served. That is an example of something that when I mentioned the board study, perhaps that's something that we want to report out regularly and be doing as part of this. That's something, again, our whole organization is looking at. So when I'm bringing to you these projections, it is, and what I'm planning to say that the next report is something that when we're looking at utilization, what they're doing with these cost savings.
But excuse me, Cindy, how do you project dollars that you're going to need if you aren't doing a projection of caseload and acuity level? The caseload and acuity level drives expenditure.
What I can say is what we look at, unfortunately, is a lot of historic. We do trend on the historic, but we do then take into consideration what we're working with as far as utilization practices, that strategic matrix that you've been seeing with cost savings. Those are types of conversations and we're having as far as a preliminary looking at what we're going to report out in the future. And again, I think I should defer this to Dave to take the next piece.
Those are very good questions, Nick. Thank you. And I've had those very same questions when I started. We're working with AFIA, and it was in their statement of work, and we're following up to get to where we can make better projections going forward. We started a ROC, another of those 90-day projects, on Monday, specific to access and our penetration rates. When we looked at the Milliman, how they develop our capitation rates, our penetration rate for Macomb County was lower, it was worse than our surrounding counties. It's definitely a concern. We want to make sure we're out there providing needed services. So we're looking at, and we will be tracking the number of people served by month and by category. As far as severity, the LOCUS is the instrument, the assessment that's used statewide for the adults with mental illness. We have the CAFIS and the PECFIS for the children. There's the CIS for the people with who have a developmental disability, but they've been excluded from any of the parity discussions at this point. So we'll be focusing primarily on the adults with MI. We're currently doing a lot of training on that instrument with all of the access managers, and we will be administering that and tracking that at the front door, but then to see if we can show improvements over time because of our interventions.
So, David, when we do a locus evaluation, which basically is a study that says what your activity level basically,
Right.
have we ever historically, maybe you'll say, I don't know.
Looked at average cost
Looked at
by,
whether or not the locus acuity estimate matches or deviates from actual provision of services?
we do not have, unfortunately, and to admit this publicly, is our locus data set is inadequate right now for us to generate that information. I can tell you I ran those reports previously, and we looked at the level of need of the assessment, and we compared it to the average cost, and there was a very nice correlation. The higher the need, the more money we were paying out for their care. We were just getting to the point where we were looking at the people who were below that line as possible underutilization and people above that line for overutilization. So for Macomb County, we will get there to where we have data that's detailed enough to allow us to do that level of drill down. Right now, we're focused on getting some baseline information in place.
So, somebody suggested we put a work group together, and I suggest that I really strongly urge that we do that sooner rather than later, because our finance, have been put into question by various folks, and some of us, including me.
I've made note of that request, and we will try to get it set for the next 2 weeks. Thank you. Thank you, sir.
Anybody else have any questions or comments on this portion? All right, part two.
Okay, so actually, the reason I asked to do the second quarter first was I thought to get the bad out and then end on a more positive note. So with that being said, our budget presentation, actually, we do owe this to the Board of Commissioners. Again, the timing is always tight. We usually have to ask for an extension, as we did again with this time. So what you have tonight is, again, a review in a similar format that you've seen in the past, showing you what the 18-19 adopted budget was in comparison to what we're proposing for the 19-20 county budget submission. With that being said, again, as even Nick commented on the contract issue, that is something that we face. How do you prepare a budget when you don't have your rates? So again, we are using the best information that we have. We are looking at historical and trending it out. What I can say is I feel, I think our communication with county finance is stronger, our relationship, and what we'll be doing moving forward is we get updated information, we will be taking budget adjustments. So for more accuracy, whether it's on the rates that we receive, whether it's something that comes down as a mandated program that we have to up our expenses. So we'll be continuing to bring those, of course, to this board first and then take those adjustments on. But again, you can see here the frustration and with the limited information. So again, we do our best with the information that we have. And we do put a lot of work into this as well, a lot of communication with our different programs and where we're going internally. So with that being said, the first page here outlines the revenue. I won't go through all of the line items. There is a lot of detail. Basically, again, it outlines our revenue from whether it's the contributions from the county, the Medicaid, Healthy Michigan, autism, our general fund, and miscellaneous areas. With that, you can see, if I'll take you down to the bottom line there, for the adopted county budget for 18-19, we had submitted $193.8 million. For 19-20, we are looking for an increase by 8.8 million, taking that revenue up to 202.7 million. And again, that's based on information that we have trending out. We looked at the revenue, which also increased with the direct care wage pass-through, areas like that, looking at enrollment trends. So that's how we came up with our figure for Healthy Michigan, Medicaid, and so on. Before I go on, actually, we did include some graphs for you as well, just to show you again where funding is coming from and how it's allocated, similar to how substance abuse did that. Actually, thanks to them for sharing some of their templates. On the funding sources, you can see for us where our majority is coming from is Medicaid, to the tune of 77% of our funding. So that again expresses that need for how we've been severely impacted with the cuts over the years, and the reason why we need to get all of our data correct and the various reports that they're asking and scrutinizing that will have an impact on our future rates. There is a Milliman call scheduled for July 24th, and we'll see what they come up with there, but I don't again expect anything firm until probably September, October. After Medicaid, you see our next highest one would be our autism funding, which again significantly still lower than a piece of that than Medicaid is. Then we have our Healthy Michigan at 6%, and then our GF down to 5% of our funding.
Nick?
I don't want to interrupt, but 77% is traditional Medicaid and 6% or something? It seems awfully low.
That's what we're seeing in our distribution.
So give it to me in dollars. It doesn't make sense.
If you look at actually the other chart, the bar chart, that shows a comparison with dollar amounts by the programs, and you can see how our funding comes in. For example, on the Medicaid, you can see for 18-19 it was 148.7 compared to Healthy Michigan of 11 million.
And how many lives?
That I don't have for you right now. I can double look at that.
Are you projecting, because you don't have a rate, which I understand, it's problematic, when you make your estimate or projection for budget purposes, using last year's rate, or are you using?
We are using the 18-19 rates.
You're using the 18-19?
Correct.
So if the rate goes up, we're shape we put down.
Correct.
Or bad shape. But you're basically basing this on last year's rate and on last year's
We're taking eligibility trends.
case law?
Well, eligibility, the trending, enrollment trends. That's all we have.
Unique members.
That's all we have.
I guess this just doesn't, it really doesn't look right to me because Healthy Michigan, the qualifications for entering the Healthy Michigan program are so much lower than what it takes to qualify in the Medicaid program. I don't understand why Healthy Michigan is such a small percentage. The budget just doesn't even make sense.
That's how it comes in on our revenue file and our distribution of it.
And that's based on current year funding.
Correct.
Okay, go ahead. It makes no sense at all because that's not true of the total pie at the state level. The Healthy Michigan program substantially increased eligibility for, the Healthy Michigan is Michigan's version of the Medicaid expansion program. Healthy Michigan, the Medicaid program, has both an income and an assets test. Healthy Michigan only has an income test and no assets test. And the reason for the reduction, at least the state gives us, for the reduction in general fund contribution is because people who used to, not true, but they argue, that people who used to be covered by general fund services are now eligible for Healthy Michigan. Okay, thank you.
Hold on, we got one more question from Kathy before we continue.
It's related to the revenue part. Can I ask it now, or did you want to
That's fine.
explain more things under the revenue?
No, that's fine.
Okay. I would say we don't want Healthy Michigan people, so we're maybe more people qualified, but if they come here, we want to get them under something else. That's my hooks. Can you explain any other major changes, that, a couple others? What is, like the, we're gonna get to that, the MISD early on, that looks like a new funding source.
Well, it's to the tune of $125,000. I know it looks dramatic. It's just some different funding that we received, very small if you look at that dollar amount.
Right.
It's just something that we didn't have in the budget last year, so you're seeing a drastic change with that.
Did we receive funding from it? We just didn't budget because we weren't
Correct.
expecting it?
Correct.
Okay, so that's really not too much of a change. It's not a new source, it's just reporting it.
Correct.
It's not new for 1920, okay.
Correct.
And then, seemed like there was one other one that, again, the numbers, the percentage seemed high, but then if you explain that you're basing it on, also the trending of usage, so perhaps if some of these are higher percentages, it's something we've seen many, many years, it's maybe more people are utilizing it, or that would be expenditure, not like, how would that go up, income-wise, revenue-wise, if more people are using it?
I'm not sure I understand your question. I guess as far as.
I'm not sure I understand yours. How is it that, I'll just, a generic question, how would we know we're getting more money when we don't know what the rates are? Or we do know some of the rates are based on what we currently have?
The
Which
18
may-
months.
Okay, which were higher than 17, 18, I mean, 18, 19, so that's why.
We're basing it on 18-19 rates.
You're basing it on
And then
18, 19
trending
rates,
it on
and the year before was based on 7. So under the 18, 19 budget line, that first column, those numbers came because we were basing it on the 17, 18.
Correct.
Okay, so because it went up, we're a year behind, but it went up, so that's up. All right, all right, thank you. I understand. Yeah, I hope everyone else does.
All right, go ahead, continue.
Okay, moving on to expenses then. Again, I won't go line by line. There's a variety of areas here. Some are driven by the county. For example, if you take the whole first section where it's from salary and wages, like life insurance, pension, and those are areas that are driven. We work with county finance, and that's provided to us. We apply that 2% increase. Again, that was given from the county, directed to us to do that. We also, though, took into consideration vacancies that we have, staff turnover, so that's why you actually do see a slight decrease in that. Moving down, again, I included both dollar change and percent, because again, depending, it could be a very high percentage change or a very high dollar change, but when you look at it in perspective, hopefully it'll clarify where the big hitters are. A few of the big hitters that I will bring your attention to down in contract services, for example, you might see it is the object code is 80128, for example. That relates to our AFIA contract. So you see that it jumps out as a high percentage, an 89% increase. There's an example. That's something that at the budget time last year, it wasn't something that was as much of an expense. Through the year, through the different contracting, that's changed. Through some of our data requirements, that's changed. The reason why you see such a significant increase. Some of the other lines that you see a significant increase again, primarily are related to our data. Even with the cyber breach, there's been things that have been on the table for years that have been postponed, but kind of on the back burner, unfortunately, because of expenses. You're seeing some of that in this year's budget moving forward. The budget actually for IT does come to you separately, and I believe that's coming to you in the August board packet. And those are built into this budget as well. Other than that, if I take you to the total here, dropping down to that, for the total expenditures, you'll see for 18-19, it was 193.8, and for 19-20, we are projecting 202.3, again, based on things driven from the state, things mandated that we have to provide in services, taking those things into consideration. It changed it by 8.4 million in increase. But the positive note there is actually when you take that into consideration with what we're expecting or projecting for our revenue, we actually are showing a surplus, if you want to use that terminology, for about $432,000. That's not been something that we've seen. So we have to provide a balanced budget to the county. So to balance our budget, we are looking to take that surplus and actually make a contribution to our ISF, which is something that we have not seen for years.
Nick?
Yeah, that's very encouraging, obviously, although it's not where we want it to be to happen. No, because we're going to get back up to the state needs to recognize that you can't do that without the rates. But the dollar figures in these various line items are somewhat confusing to me because there's pretty wide swings from the current year in a number of areas. For instance, on the revenue side, you're projecting flat rate. You're calculating this based on a flat rate, right? I'm saying
From 1819.
from 1819 to 1920, because you don't have a rate, the rate you're using is the current rate. That's what you said before. So then I look at Medicaid amount and what our current budget was, and I'm seeing a 21% decrease in Medicaid revenue. How do you end up with 21% less Medicaid revenue if the rates are exactly the same, unless you're talking about less people on service?
Well, if I can clarify, where you're seeing the 21%, the Medicaid is across numerous lines here. There's different Medicaid, there's different ones that are out of GF, they're allocated over across lines, so you really just can't look at one line.
Well, at Healthy Michigan, you've got a 4% cut. My Health Link, which is Medicaid money, has got a 17% cut or reduction. 100% Medicaid, you've got 1% increase. Then you've got another Medicaid line with a 2%, so the child labor program, 2% cut, and a 21% cut for Medicaid. There are basically three programs that we run. Medicaid, there's more than three, but three Bs, Medicaid, Medicare, Medicaid, Healthy Michigan, leaving substance abuse aside because that's a different track. Medicaid over here, that's the PIHP piece, and general fund, which is the same as the speed piece. And what I can't figure out by looking at this is how we end up with a 4% increase in revenue if you're projecting reductions in Medicaid dollars across the board. There are a lot more minuses in the percent change. I didn't do the end because the percent could be, literally dollar items, which is looking at those dollar amounts. If you added up all of the money you're projecting we receive from the state for regular Medicaid and for Healthy Michigan, which is basically the PMH pool, right? What is that and what are you projecting to change from year one to year two?
That's actually, if you looked at the bar chart, it's summarized more by those programs. This revenue sheet, again, with the numerous line
Oh,
items,
I see.
when we receive our Medicaid dollars in, it comes in a revenue file that is, I think we've talked about this in previous board meetings over the
I
years.
see.
We don't get a monthly, here's your Medicaid number. It comes in a format that we actually do have a FIA currently that downloads and works at deciphering that information. What we did is summarize it on this chart that shows you in total all of our line items for Medicaid. You can see levy for 18-19 was 148.7, for example, and for 19-20, we're projecting it to be 156.4.
So that's basically,
The
we have all those
summary.
different lines that show up in different
Correct.
places on your revenue line items.
Correct.
When you aggregate them, that's what the margin. Okay, that makes sense. Now, when I look at the expense side, there are some pretty big swings. You said you may want to change your heading, because I was confused for a little while because I couldn't figure out how salary and raises was listed as a revenue. That's, you got it on the top, right, but on the chart it says the revenues and some expenditures. But for instance, there was an increase in salary. You're just taking flat out dollars for things like salary, wages, like hospital, dental, retirees, all of the pension, the employee-related costs. You're just taking whatever the county gives you, plugging them in. You're not taking projections.
They send us a file that we work with, that's our starting point. And then, like I said, then we took into consideration some lapse due to, again, staff vacancies and turnover.
Because it's hard for me to understand a 5% decrease in salary and wages when our employees got a slightly better than 2%. Unless you're dramatically reducing the number of people, and I know employment, you're not letting tons of people off. But my understanding is if I look at these two numbers, the county budget submission and the 18-19 dollars, those aren't your projections, those are what the county finance department gives you. So this is how much, this is what they do, they pay for it.
Correct.
So you don't have to worry about that, that's basically their budget.
Nick, if I could too, Cindy included the assumptions as footnotes. And we also, Cindy and I met, and some of these categories are carryovers from times gone by. So we will be working to identify them so that she and I are both clear on what they represent and where those numbers are being pulled from. And that is something we'd be happy to share at the study session.
Sure, and I suspect part of the problem is when you look at, if you're looking at actual, the fact is we have a significant number of unfilled positions that we haven't filled for technical reasons, for other reasons, and also to try to keep it in the budget. So
Right.
you've got FTEs that are theoretically funded, but we're not expecting. So which are you listing here? You're listing what actually we spent, or you're listing what we have budgeted?
It's listed under the assumptions, the salaries and wages. The budget is based on current salaries and vacant positions, calculated at a minimum pay rate for that position. Salaries include the 2% increase. She applied a lapse to account for staff turnover and unfilled vacant positions.
Okay, I'm getting two different answers, I'm trying to figure out which it is. This says we are doing the calculation for salaries and wages. I thought I just heard the county's telling us.
We're using their file as our starting point, is what Cindy said.
And I guess I have some questions as to why we're doing that, because if we're talking about a position that hasn't, first off, why are we calculating a minimum pay rate for the position when in fact most of the positions aren't at the starting point?
If it's vacant.
If it's
we're-
vacant.
We're using the minimum.
So your salary and wage line assumes that we fill those vacancies and is budgeted to fill them? Or it's?
No, we actually did some cleanup this time with specific to the positions. We had in the past left some numbers, left some positions open. This reflects some cleanup. And again, we can get that level of detail to you after this meeting.
Yeah, that's fine. But I'm just trying to figure out what this reflects. confused as to what this says. We're taking actual, what we paid them, the wages we got, and then adding to that minimum cost if we did fill some of the vacant positions.
It's based on the current salaries and the vacant positions at the minimum rate.
So you're assuming you
Plus.
fill all of them.
We're not going to fill some of those vacant positions, and that was where some of that cleanup was. So this is a better projection, closer, tighter going forward.
I just, it doesn't, you're making sense to me, except I'm missing something here. I'm trying to figure out whether this number is what we're likely to spend based on the assumption that we fill all of the vacancies or we don't fill.
It gives me the flexibility to use some of those positions as needed going forward.
I understand, just because we budget money doesn't mean you have to spend it, but you
Right.
have to spend it. So when you're calculating the budget line item, those salary, wages, and all of the purchases that goes with it, you're budgeting based on actual plus minimum level for all of it.
Or
Even
positions
though you
we,
may not fill all.
Just point of information, one of the columns we are missing is actual expenses for this past year. So there could be a variance from the budgeted amount from the 18-19 budget to actual spent. We don't have that information. So maybe that would be another thing to just get to have for.
Yeah,
So I would imagine that factored into it, but we don't have that here. So, good question, but let's try to get more information. We can't get it here tonight. We can't get it tonight.
well, we're being asked to adopt the budget recommendation, and I don't know how I vote for a budget recommendation if I don't know what it is.
Well,
We
okay,
can
that's
get
your choice. That's your choice.
Yeah, I mean, I'm just trying to figure out what you're proposing. And Kathy's right, traditionally, we've had an actual column. We don't have
I don't think we have. I don't think we have
Yeah,
that.
we have. We have it.
The board of commissioners. We do. Okay.
I don't know what you put in, yes, but we traditionally, in our budget, in the request from the CEO to us for a budget submission, I know you're under a time crunch, but you gotta get the budget into the, to the exec's office by when?
Tomorrow. In all reality, they did want at least a draft. You know when our meeting is this evening, and they're expecting at least a draft of it tomorrow.
So hypothetically, we change these numbers or reject it, it wouldn't matter?
Well, again, even when we're working through this, what I had mentioned about budget adjustments, as we get better information, we'll continuously be going back to them with those adjustments.
Again, I think a lot of that needs to be discussed.
right, you do, this body does control what goes forward from here. So if there was changes to this, that would be reflected in what goes on to the Board of Commissioners. Or if there was a request that it not leave, I would believe that would be within
Well, the request, so if I understand our system, the request goes from you to the exec's office, the exec's office then presents the budget to the county board, and the county board adopts the budget subject to the veto power of the exec, right? So we're at the stage now where we're sending a department or agency budget submission to the county exec in hopes that it will incorporate that expectation that it will incorporate that change that in his budget submission to the county board of commissioners.
Right. And Cindy and I presented to the Board of Commissioners Health and Human Services Committee, and their request was for additional detail. And we told them that after this board had approved that information, we would provide them a summary and an update. So we owe them that and the budget information for next year.
That's not occurring, but for the budget submission, just so I'm clear, the process, the stage in the process that we're at right now is you're submitting the proposed budget
Commissioners elects all of you to be here. So I would recommend it also go to the board, which it is. Just throwing that out there, Nick.
Well, the board has the final say.
Right.
The budget, so, but the process is the exec proposes and the committee,
Right.
you're the legislature.
And the update coming from Dave and Cindy to the Board of Commissioners was going to happen last time, but because of the computer issues, it never happened. So that's kind of why.
You want to make sure we keep the board of commissioners in the
Yes.
loop of the update.
Yes.
I see.
And that's why it just didn't happen last time because of issues, technical difficulties. All right, any questions or comments? All right, seeing none, we have a motion and support to move this to full board with recommendation to approve the budget. All in favor signify by saying aye. Aye. All opposed?
I'm doing
Yes.
that. Yes, sir. That's under Robert's rules. You sound like Lou Bird.
Nick wants to pass.
Well, someone's got to fill in for
Yeah, I knew it was always wrong.
Nick is
You
passed.
have to say why you're abstaining.
Because I'm not ready to vote on this until we get a lot more questions in the works.
Okay. Motion passes with one pass from Nick. All right, next we have a receive and file the Macomb County Community Mental Health Financial Status Report, Executive Brief, Mid-Year Report, Fiscal Year 18-19, which we just received. Take a motion to receive and file. Motion
Support.
from Megan, support from Selena. No questions? Good. All in favor signify by saying aye. Aye. All opposed? It has been received and filed. We don't have any resolutions on the agenda, but I have a note in front of me, and I want to read it real quick. In May of 2018, one of our longtime employees suffered a major medical problem and subsequently retired in September of 2018. Because of the illness, recuperation, etc., Virginia never received a resolution that most employees receive when they retire. And rumor has it that Virginia would really like a resolution. She is doing very well, and with the board's approval, the resolution will be prepared and approved by the board at the July full board meeting. Just throwing that out there so there's no surprises on the next agenda for Nick or myself. Next is other agenda items. Is there anybody, any board member, and then I'll turn it over to Dave. Linda?
Forgot your name. Phil,
Hi.
could you just fill us in a little on the board's action on filling the vacancy of John Flynn?
We have had 0 applicants.
Do you have a date, or do you have a?
We have a date, but I know we've pushed it because we have none.
Okay.
I know it's been posted everywhere. I just talked to our chief of staff earlier today. Do you know what the date is, Barbara?
The application had to be in today.
Oh, deadline was today, so,
Okay. That's
but it
an
has
update.
been extended. I don't know
Thank you.
how long it has been extended to.
Okay. And then my other question is probably for Dave. And, you know, we have a lot of new board members who weren't here when Lake Shore got the bad news the first time and all of that. And so, I just looked at it again today, and they're still, so Lake Shore didn't perform, and they lost their director, and then they had somebody else come in, Beacon, who we consulted about coming here, and they have kind of, I'll use the word failed, my word. And so the system hasn't been able to improve with all the things that have been expected of it. So is it not gonna, I mean, is it like what I'm thinking, underfunding, and there's no way to fix it anyway? But why are they doing the letter instead of fixing the funding, is my question. So could you just give a little report on Lake Shore, Dave?
Yeah,
After
I
my
can't answer the
editorial
question
comment.
about
Right.
why aren't they just fixing the funding.
Right.
Lake Shore did receive the notice of contract termination effective the end of this fiscal year. They have, I was on a phone call with, that included the executive director, the CEO of Lake Shore's PIHP. They are pushing back against the department. They're sending a formal letter. It's going to point out the fact about the historic underfunding, and then the state's using their lack of funding as the reason they're terminating their contract. So it's not playing very well. That and the state's plan involves moving Beacon into the role of the PIHP. What I was told was that the state had not even reached out to Beacon before they issued the letter to Lakeshore.
And isn't Beacon the one that's failed this time to get the letter, when they got the letter? Right, I mean, Beacon.
It depends on who you talk to.
Okay.
Beacon was the entity that the state contracted with to do the Beacon report back in 2015, 14, 15.
Dave and I have been on the phone all day, I think, today. And
Yeah.
I've been on the phone with the governor's office trying to figure out even what the state is proposing.
And
And
then-
we're getting different answers. What I would urge, I intend to put this on our legislative policy committee for further discussion, but we'll be here all night literally just trying to guess at what the proposal is. Because what the governor's office told me, what he learned from Beacon, it doesn't make sense. They conflict with each other. So we've got to find some more, to give you a credible answer. we got a lot more research to do, and I want to put that on our agenda with the chair's permission of the legislative policy committee, so that at least we know what's going on and what implications it has for us down the line, potentially down the line, what it has implications after 298. It is the answer to most of your question, Linda, is, I don't think we really know.
Well, I didn't really have a question, I wanted a report, so.
Yeah, and he's giving you the report, and I can give you what I got, and we're getting different stories from different places. We're trying to sift it through to come close to what the truth is. Is that a fair observation?
Oh, very fair. I will be with the department tomorrow morning, so hopefully I'll have an update tomorrow afternoon. A couple of other updates. Kimberly Cope, the compliance and privacy officer, she did resign. Monday the 15th will be her last day, and I believe she's working half a day in there. I did have the opportunity to meet with her briefly. She's assigned out all of the tasks, tidying up everything, so leaving us on good terms. I did meet earlier today, and Laura Manza has agreed to be our interim compliance and privacy officer. Laura served in those roles a little bit, and I'm looking at Cindy for she's nodding. Laura is an attorney as well, and comes with good background, and she was very excited to be able to take that role. So it'll be a temporary reclassification while we post that. If you recall, this board approved changing that position to the director as the chief compliance officer, and we're still waiting on some activities at the county level to clarify that. But we will hopefully fill that position permanently as soon as possible, but we have an excellent person who's willing to help cover that for us. And those positions are required by contract as well. I'm not sure how to handle this either, but I realized that we do have an active lawsuit, and that you all should probably be aware of that. It was issued by a local health system, and we feel we're on good grounds. We've actually countersued, and so it's in process, and I can continue to provide updates or give you additional information now if you would like.
I prefer that if we have attorney present, go into closed session.
Yeah, would be fine.
But thank you for the notice.
Good news, our new phone system is moving forward. Adam had the most recent update. You want to?
Yeah, so the phone system provider is having a meeting on Friday to discuss the rollout, the implementation of it, and we're going to have a meeting middle of the next week to schedule the actual implementation of the phone system. So we'll have more information next week.
And I think our folks at the Access Department are doing a little happy dance. They've had numerous phone issues as the phones have just quit working underneath them. We were able to get the old phone company found some old phones that they had mothballed that they weren't doing anything with, and we were using those temporarily. But we will have a new phone system, which hopefully will improve the customer service and the experience for everybody involved. And those, I'll leave everything else until the full board. Thank you.
Kathy?
Thank you. So we determined we wanted to have a work study session regarding how the reports are presented to us. So I would encourage everyone to put your questions, and if you can't form a question, just put your frustrations or whatever it is you need to know. Send it in an email to Dave so that they're all in one location and so that they can prepare the meeting to coordinate with that. If you have other issues regarding finance, put those in there too. That might not become part of this work group, but maybe we form another work session for something later. But I think it's important that when we do these work sessions, it relates to things we want to know. They're not going to know. Some of it just from questions asked tonight they might know, but let's really make it a point to be very specific. Or if you can't, as I said before, if you can't formulate the question, because when I first started, I didn't even know what question to ask. So then just say, I don't understand, and put that in your email. So, thank you.
Megan?
Just wondering, are study sessions or work sessions, are they typically the 7:30 meetings or are they evening meetings like this?
It's up to the board when they would like to meet.
And I was just finally starting to understand and navigate what you've been giving us. And now we're going to change it all over again. Anybody else have any other agenda items? All right, seeing none, we will close that portion and go to hearing of the public.
Good evening, I'm Lori Doyle and I'm the peer coordinator. And I am here because I met Madam Chairperson and she wanted to hear some good news once in a while. So I'm here to share my story and how CMH helped me. I've been working at CMH almost 4 years and I was promoted to peer coordinator about 1.5 years ago.
Excuse me, could you explain what peer coordinator is in case some of our new people don't know?
Sure, sorry. I kind of oversee the peers, but I'm not their supervisor. I try to educate them on the best way to serve the people we serve and coach them, make sure they have everything they need to do their job. Okay. So, to get into my story, I was married with 2 boys, Michael and Ryan. I got a divorce, and then I decided to go back to school, so I put myself through school and got a degree. I graduated with honors, and down the road, I got my dream job. I was a consultant for, my education was in IT, so I was traveling across the country implementing provide software, and it was a great job. The money was good, and then my son got into drugs, and he would always. I would bring it up to him because I knew something was going on, but he would deny it, and I just felt like my hands were tied until he would admit to me that something was going on. So he finally came to me one day and he was crying and said, "Mom, I just can't live like this anymore." So we got him into rehab and he was doing good, and then he relapsed. And so he started using again. And then came the day that changed my life forever. I went to check on him. It was early in the morning, and things just didn't seem right, and I realized that he was gone. And this just sent me into a downward spiral. I just didn't want to live. I really didn't care about anything. I lost my job. It was really tough. And then 2 months later, my brother passed away. So I was really in the depths of depression. And 5 months had gone by. I had no job, no insurance, and things weren't looking very good. And then my family did an intervention, and they helped me to get into treatment. So I wound up calling the Access Center, and they referred me to outpatient treatment. And it was a struggle to keep my appointments because I didn't want to deal with anything. But I did. And so I was diagnosed with major depressive disorder, anxiety, and PTSD. So for the next 2 years, I kept up with my treatment, and it really helped me to understand drug addiction, because I couldn't understand why my son made all those decisions that he made. So it's really helped me to come to terms with things. I still wasn't working, and every time I got mail or the phone rang, I would sink into anxiety because I knew it was the bill collectors. And then I did lose my house, and I had to move in with my parents, which it was really a struggle after having my dream job and then all this happening. But after moving in with my parents, I wasn't isolated anymore, and it really helped me to start feeling better. And then I decided that I needed a career change. I knew that I wanted to use my experience to help somebody else, and I thought if my story could just help one person, some good could come out of what happened with my son. So I contacted Michigan Rehabilitative Services, and I worked with them because I didn't know what to do with myself. And honestly, they didn't know what to do with me either. And I worked with them for a few months, and we just weren't finding anything. And then my job coach gave me a flyer on a peer forum, which was an informational session about being a peer support specialist. And I thought, oh my gosh, this is perfect. So I went to the forum, and I knew that that was what I wanted to do at that point in my life. And so after 1 month, I was called for an interview, and then I had a second interview, and I got the job. And it really helped me to work with people, the people we serve. And it made me realize, too, that as bad as you may think things are for you, it could be a lot worse. I mean, some of the people we serve are really struggling. And so it helped me to be thankful for what I did have. And what I did have was a great family who supported me and friends. And I also had good treatment that helped me to work through these issues that I had. And I also had, and I had a job, which to me was very healing. It just gave me a purpose again in life, which was really important. So this is one of the best jobs I've had. I really do enjoy it. I've worked with some great people, and we provide an important and much needed service to people. I had no insurance and no income at the time, and I was able to get treatment. So we can really help people. So thank you for your time.
Thank you for coming and sharing your story and everything you're doing. We appreciate it. Thank you.
Thank you very much.
Anyone else from the public wishing to speak? Going once, going twice? All right, we will close the hearing of the public. With that, I'll take a motion to adjourn. Motion from Megan, support from Linda. All in favor, say aye. Aye. All opposed, we are adjourned. Thank you, everyone.